waste that they cannot remove because the kidneys are not functioning. The most common reasons for kidney failure in America are diabetes and hypertension. So if we really can prevent through these screening campaigns people from at least to be aware that they have a blood pressure problem, then we can do a lot to prevent that. This year, 100,000 new patients will get into treatment for dialysis. So it's something that we can prevent. So just very briefly review a little bit of physiology of what we're going to try to learn later on by the trainings and blood pressure reading. This cartoon just depicts the cycles of the heartbeat, you know. When you put a stethoscope in the chest area, you will hear this lump sound. So the very first sound is coming from this contraction of the heart, and the blood is coming out through all the big vessels, the aorta and the pulmonary vessels. And the dupe comes when the blood comes back. But we don't listen to those sounds when we measure blood pressure, so don't get confused. The loud sound of the heart is not what we measure here. But we refer to systolic blood pressure and to diastolic blood pressure. Why will that be important? It's because in systole, you squeeze the heart, so there will be a pressure rate that is transmitted to the blood vessels. And in diastole, the blood just returns. So that will also confer something. If you place a stethoscope in one of the large arteries that we have in the radial side or close to the elbow area, if you place a stethoscope, you will not listen any sound. So when we try to determine systolic or diastolic blood pressure, we have to use some tricks, and that's what we are going to talk now. So to measure blood pressure, we need a stethoscope. Well, this is kind of a fancy stethoscope that is used when people are being trained how to measure bleeding. This could be placed on the ears of the person who is already trained, and this could be placed on the ears of the person who is being trained. But we will not use those. And they will just go ahead and use one for each one. So these are the devices that we use. This is a traditional mercury-based column where we inflate this cuff and we raise this mercury column to some number. Okay? But you will see that here we are going to use a different device that is just based on the cuff. Is that one? Yeah. So this will be different. The cuff and the reader of the blood pressure is here. These are more what people can get it to get blood pressures at home. You know, with technology now you can do electronic readings. You don't need to put your ears there. The device can record blood pressure and can give you readings of blood pressure. So what do we do technically to get the blood pressure? What we do is basically we place this cuff in this area on top of that brachial artery. So there's a cuff that wraps the arm, and then we just inflate this. Okay? So we will inflate this after we apply enough pressure there that there will not be. So once again, if you place an stethoscope here without applying pressure, you will not see, you will not listen sounds. It's only when you inflate this, and this is the way how it's placed. You palpate the artery, and you place the stethoscope. You ask the patient to be seated in comfortable position will depend whether or not the arm is at the heart level. That will be the accurate reading. If it goes above or lower, we give different readings. And what we basically try to do is we apply enough pressure, and then we slowly, the book said 2 millimeters per second, we open this release valve, so the needle will start coming down, okay? And whenever you hear the very first sound, is what we consider the systolic blood pressure. So once again, if you apply an stethoscope to this tube, there will not be sound. But when you inflate the balloon and you press this, when the heart is doing an excursion, then you will see, you will listen a sound. And it's when the sound, the progression of the sound over time, as you release the valve. This example, at 120 millimeters of mercury, you will listen to the very first sound. And as you reduce the blood pressure, the sound will disappear because there will not be more resistance to the blood flow. And that measures the diastolic blood pressure. So the top component comes from the squeeze of the heart that is passing through a blood vessel that is very compressed. As you start releasing the compression, the sound will disappear. And once it disappears, that's the reading of the mono number. So once again, the position of the patient is important. He has to rest, they say, at least 5 minutes. When patients go to the office, sometimes they get scared because these doctors are telling them you are sick, you know. So as every human being, we will be fearful and we will release hormones, like we will be afraid, you know. And just that condition can raise your blood pressure like an artifact. So to get an accurate blood pressure, you have to allow the human being to rest, to take it easy for 5 minutes or so, and then you start getting the readings. Because suppose that you are rushing to this meeting and you arrive and we take your blood pressure, it will be completely different from 15 minutes when you are here already. Sometimes in the office we can take it when the patient is standing. We have to be sure of. This is very important. The bladder length has to cover at least 80% of the arm. So because if I really have a huge arm, this will not be enough, and that will create inaccurate readings. So the cuff has to be sized according to the body size of the patient. In very obese patients, we need large cuff because their arms are very big. So the bladder length has to be at least 80% of the circumference of the limb. Because if I'm a very obese patient, you use a too small bladder, you will overestimate the blood pressure. And if you use a bladder that is too large, you will underestimate the blood pressure. Those things will be explained much better by the people who will provide the training. But that was basically what I wanted to give you a brief heads up of what we are trying to do. Once again, by placing this large bladder that is occluding this artery, once the heart squeezes and the artery is very squeezed, nothing will pass. You know, no sound will pass. But as you are releasing the valve, the impingement of the blood vessel will be less, and then you will start listening to a sound. And that will be your very first Korotkov sound. Korotkov was a Russian physician that described these sounds in the 1800s or whatever. So that's why we gave that name of the Korotkov sounds. So what we try to do is with the stethoscope, catch the very first time that the sound appears, and also catch when the sound is gone, when it face on. All right? Questions? So, in these screening campaigns, we check blood pressure, we check the urine to see if there is abnormal amounts of protein, because all those things are kind of hints or red flags that those patients can develop, not in a day or 2 weeks, but in years, then problems. So if we make them aware, then we will save this 100,000 new patients going into dialysis. Right? Thanks for coming. I'm so excited that you are creating this group. And
yeah, thank you, Dr. Bernardo, for...
Yeah, I would like to stay, but I'm on duty. I'm